Hello and welcome to the lecture recording of the initial patient assessment of a vented patient. So this is when we put someone on mechanical ventilation. We're going to evaluate them. We're going to look at different things like lung characteristics. We're going to look at the circuit to see if there's anything there that needs to be addressed. We're going to look at how the patient's interacting with the machine. We're going to make sure everything's appropriate. What do we document when we put someone on mechanical ventilation? So that's all what this will encompass, and then so much more. So let's get started. All right, so these are our learning objectives. The first thing is to understand the importance of performing this initial ventilation procedure. So that's what we're going to be looking at. Why do we do this? What's the importance of it? Why do we need to do it? The next one's going to be look at the recommendation times, or how often we look at this. When we're looking at oxygen analyzers, looking at FiO2, things like that, making sure our machine is working appropriately. And then finally, identifying various pathophysiological conditions that alter a patient's trans airway pressure, like wrong compliance, peak airway pressure, plateau pressure, making sure that we're evaluating those because they can tell us about the lung mechanics. We can see how the patient's disease process is going, if it's getting worse or improving, if it's severe enough, if we need more aggressive interventions. So that can be a good hint for us. And so we need to trend those, and that's one valuable thing about doing our assessments. All right, we're going to use pressure time curves. We're going to look at how we look at some of the graphics here. And then we're going to look for different things like leaks as well, being able to identify a leak in the circuit. And then making sure that we're looking at things like pneumonia, ARDS, right? Filled chest, pneumothorax. We're going to look at our physical examination of this patient and how that interacts with the ventilator. We're going to determine whether a lung compliance problem or an airway resistance problem is present. So we need to look at the differences there, and I have some comparison slides, some practice slides in here. We'll also look at a flow sheet, a ventilator flow sheet, and then even looking at PIPs and plateau pressures and all that stuff there. We're also going to evaluate static pressure curves to look at dynamic compliance and static compliance, and then we can see what's going on with their resistance as well. And then we're going to estimate their alveolar ventilation based upon their ideal body weight, their tidal volume, their respiratory rate. Alveolar ventilation is what actually participates in gas exchange compared to just good old-fashioned rate times tidal volume, which is minute ventilation. Alveolar is how much actually participated in gas exchange. So we're taking dead space out of it, so we'll get into that as well. We're going to detect a cuff leak by listening to breath sounds. How do we listen for a cuff leak? What does it look like? Do we need one? Should we have one, right? And then we'll look at recognizing inappropriate endotracheal tube cuff pressures, right? This can be very damaging to a patient if it's inappropriate. And then recommending pressures that are correct and procedures that correct these problems. And then we're going to look at information on pressure controlled methods, whether compliance or air resistance have changed, right, in different modes. And then our last objective slide here is to look at the technique for measuring cuff pressures using manometer and a syringe and a three-way stopcock. I did this myself for many years. And then describe two methods that can be used to remedy a pilot balloon line that has been cut or altered. So that can happen from time to time. No one's perfect. That includes me. So it's good to know what to do if that happens. Don't focus on necessarily the problem in front of you, but focus on fixing the problem in front of you. All right, so let's start here, our first slide. Once a patient's on a mechanical ventilator. So when we're looking at a patient, how do we assess them? This patient's on mechanical ventilation. So first things first, we should look at things like the patient's skin color, their respiratory rate, their breathing pattern. Do they look pale? Are they sweating? Are they mottled, right? Or are they pink and well perfused? Is their skin cold and cold? Is it warm? Is the respiratory rate really, really fast or Are they riding the machine, right? Letting the ventilator do 100% of the work? Is their breathing pattern appropriate? Are they using accessory muscles still? Believe it or not, if your vent settings are inappropriate, you can still have the patient use a lot of accessory muscles. What's their chest movement? Do they have a seesaw pattern? Do they have retractions, especially in pediatric patients? What are their breath sounds? Do they sound coarse? Do they have crackles? Do they have wheezing still going on? Do they sound clear? Is there hardly any air movement? Are the breath sounds uneven? Right? Things like looking at this patient's work of breathing and even their level of consciousness on mechanical ventilation. All of these can provide valuable information about their physiological status. So when we're looking at these things, these observations that we were just looking at with the breath sounds, with the work of breathing, level of consciousness, everything there, plus the information provided from the ventilator, can help us look at this patient. Even when the ventilator will give us hemodynamic monitoring, or the hemodynamic monitoring gives us that valuation, we're going to look at these things when the patient's undergoing mechanical ventilation. It's going to give us a whole big picture. It's going to give us lots of important information. When we're looking at this, we're going to look at documentation of how the patient's doing with the ventilator interaction. So after they've been placed on the ventilator, we need to document what's going on. What was their peak pressures? What was their plateau pressures? What was their heart rate? What was their breath sounds? We need to trend these things. We need to communicate these things as well. So not only do we use our charting for trending, but we also use them as a method of communication, and it helps us see how the patient is progressing, or how the disease that the patient happens to have is progressing. So we're looking at this, and one of the first things that we're looking at is involving verification of the physician orders for mechanical ventilation. What's the specific orders for this patient? Is there orders specific to the ventilator settings? If they are, do we have those in place? Once the physician orders have been verified, right, this is communicating, then the respiratory therapist ensures that you have passed, the ventilator has passed an operational verification procedure, right? So this is that OVP that you'll see in the slides here. The OVP is usually the policies and procedures that the respiratory therapy department has. So it's important that the respiratory therapy department really maintains records showing that the OVP history for each ventilator. So most ventilators will have a record showing what changes, what procedures, what tests have been done now. So that is something that's a lot easier nowadays as far as that goes. In addition, there should be a label or a form should be attached to each ventilator showing when it was performed, when the OVP was performed, by who did it, right? Who did this operational procedure, whether the ventilator passed the multiple part test. And a lot of times this is recorded on the ventilator when the last time it was done as well. So newer ventilators really are designed to perform a series of automated self-tests once you initiate this process. The self-test might be part of the OVP, so that's something that's easily put into that protocol. The equipment evaluation process should involve checking the integrity of the ventilator circuit, which is part of that usual short self-test, or SST, that we do before we put the ventilator on a patient. One of the things that you're also looking at, besides the circuit, making sure everything's good to go there, is the humidification you're going to use, and ensure that that equipment has been correctly attached and tested to ensure it's free of leaks. I cannot tell you how many times I've hooked up a patient where the circuit was backwards, or where there was things that were abnormally set up about that patient. So one of the things that we're going to have to look at here is making sure it's all good to go before you attach a patient to it, and that's part of it. So once you place a patient on a mechanical ventilator, we need to make sure that everything is as it's supposed to be as well. So we make sure it's good to go beforehand, and then we place the patient on the ventilator. Now we need to still make sure everything is as ordered, or should be as it should be. So one of the things that we'll look at there is make sure the that we're appropriately supporting the patient, especially per either mechanical ventilation guidelines by the respiratory therapy department or the physician's orders. We've got to look at the desired range for the PaCO2. Sometimes patients might have what's called a transcutaneous pressure. That's a little Clark and a Severinghouse electrode that's attached and put to an area of the skin, right? It's transcutaneous. It heats up the skin, and then it will arterialize it. It will bring more blood flow there, and it's going to read more accurate CO2 levels than oxygen levels. So why CO2 levels? Well, because if it heats up the tissue, then it's going to increase oxygen consumption and therefore underestimate how much oxygen is actually in the patient's arterial system. So we trend it more for CO2 than PaO2 than oxygen, right? So we trend it for more for CO2 than oxygen. I'm a huge fan of end-tidal carbon dioxide, which is what you see here. End-tidal carbon dioxide is one of my favorite assessments to do on these patients. So that's end-tidal CO2. I always enjoyed using this because it can tell me if there was a dead space process going on. It could always tell me if the patient's cardiac output is changing, right? If their perfusion's starting to go downhill, if they start to lose vascular tone or cardiac tone, then that end-tidal is going to drop. If they start to have a dead space process where I'm hyperinflating the lungs and impeding blood flow through the lungs, then the end-tidal CO2 is going to drop, right? So it can be a very valuable assessment, not only for ventilation standards, but also for perfusion standards as well. PaO2 from an arterial blood gas, pulse ox, non-invasive, SpO2, transcutaneous oxygen pressure, we can look at that as well. And SaO2, right? SaO2 from the ABG is going to be your gold standard, and PaO2 from ABG are your gold standard. Same thing with CO2 from ABG are your gold standards for ventilation and oxygenation. So gold standards for ventilation and oxygenation are off of arterial blood gas, not from non-invasive monitoring. Ventilators, ventilator variables can be initiated or manipulated to achieve the desired ABG goals. So one of the things that we'll have in our event settings or event parameters or orders is to titrate their minute ventilation to get a goal of a pH 725 and above, or a CO2 of 55 or below, right? So one of those things we'll have to look at is changing our vent settings to reach those goals, and we'll talk about actual over desired if we haven't already. And then even with oxygenation, so on ABG, CO2 looks at ventilation, and PaO2 and saturation looks at oxygenation. So what are some vent settings that change ventilation? Well, vent settings that change ventilation include rate and tidal volume. Rate and tidal volume. Now, those are the things that we might manipulate to help improve mechanical ventilation, improve PaCO2 levels. What about oxygenation? Traditionally with oxygenation, we're looking at PEEP, mean airway pressure if you're on something like the oscillator, but PEEP and FiO2, right? PEEP and FiO2 are going to be your big ones to manipulate oxygenation while on mechanical ventilation. All right, so let's talk about documentation. I know this is probably your favorite thing to talk about here, but when we're documenting the patient ventilator system here, the patient information in the ventilator settings should be documented regularly. So traditionally, when we're doing this, the frequency the ventilator system checks depends on the institution's policy. I've seen some places that'll do it every 2 hours. I've seen some places that'll do it every 4 hours, but generally they're performed every 1 to 4 hours, depending on the policy, and it really does depend, right? So when we're looking at these, before ABG is drawn, we should go ahead and do a ventilator assessment and record the settings. So that tells us why before, Derek? Why would we do it before? Well, that tells us at the time of the blood gas what was going on with the patient. Not, okay, 4 hours previous to that, there was some ventilator settings. I don't know what the patient was doing right before you drew the gas. I want to know what they were doing right before you drew the gas, because is it possible they can be breathing faster than they were initially? Absolutely. So I want to do a vent assessment. I want to record my values, my compliance, my resistance, my pressures, my tidal volumes, my exhale tidal volumes. I want to record everything, my breath sounds. I want to record everything as much as possible before I draw that gas. So that way I know at the time of that ABG what was going on with that patient, so we can make a better plan about how to make appropriate changes, right? So before an ABG sample is drawn, I should do a system check. When a patient has entered new orders, when we change a tidal volume, when we change a respiratory rate, when we make any significant changes to mechanical ventilation, we should do another check to ensure not only that the setting, to record when that setting happened, when that change happened, but also the patient's interaction with that change. Was it a good, safe change? Did they have an adverse reaction to it? We don't know unless you do a full ventilator assessment afterwards. Before we do any hemodynamic data or bedside function data like compliance studies, things like that, optimal PEEP studies, we should do that to see where they were at before, and then we can compare how they did afterwards, almost like a pre and post pulmonary function test. If we increase mean airway pressure, if we increase PEEP on a ventilator and the patient's hemodynamics go downhill because we're causing vena cava compression, well, then we don't know that unless we recorded that hemodynamic data before and after. So before, hemodynamic data or bedside pulmonary function data are measured, right? And then after, the ventilator change has been done. So that's one of the things that we have to look at here is, okay, once we do it, how did the patient interact with this? Right? And so this procedure can vary when we just talked about this. And then anytime there's a question in whether the ventilator's performance is optimal, we should go ahead and do a vent assessment as well to make sure that the settings are all appropriate and the patient is interacting. So the patient ventilator system checks represent a documented evaluation of the ventilator's function and the patient's response to that ventilator support. So we have a machine that's trying to give a patient support, and what's the patient's response to that? And we need to look at that communication. We need to look at that interaction. So the big thing should be emphasized, right? Data that is relevant to the system checks should be recorded on the hospital form or the patient's medical record. There are some places that might still have paper charting for this. Most places by now, I'm sure, do a form of computer charting, but they need to be recorded. The check should include observations of the ventilator settings at the time of the check. So I don't want to just go in there and write my name and say it was this time, right? I want to record the settings, what the patient was on when I went in there. The record should include the physician's order for vent settings at some point, all right? And make sure that the patient is still under those orders. The ventilator system check could include a brief narrative of your observations. Hey, the patient's noted to have retractions. They're noted to be using accessory muscles while on ventilation. They're noted to be working hard using accessory muscles of forced exhalation or accessory muscles of inhalation. They're diaphoretic. They're pale. They're mottled, right? That would be narrative clinical observations of their response at the time of the check. One more note real quick about the physician's order for the vent settings. Every once in a while, could someone change a vent setting and not know it? Absolutely. So if something's changed, we need to note that and understand who did it, right? And sometimes they just didn't update the order. That order needs to be updated, but that's going to be helpful as well. But that narrative of clinical observations, back to that, at the time of the check is going to be important to making sure that the ventilator assessment includes a picture of what the patient looked like when you went in to see him. Now, most of the time there's a ventilator flow sheet, and I have an example in here that records the system check data. So at the top of the form, you have a basic patient information, including the name, other data like their weight, age, height, ideal body weight, body surface area, the medical record number sometimes, their diagnosis, their physician, who the physician is, along with their orders, what date they were intubated, what their ventilator start date was, right? What ventilator day they're currently on, right? How many days has this person been on the ventilator? In addition, when the ventilator was SST, the OVP, right? Patient information and vent settings should be documented pretty regularly when they're on vent support. So a lot of times, like I said, this is on a computer software program of some sort. Or there might be still places that keep a paper record, especially backup in case the computer system goes down. But regardless of the form it takes, documentation is often called the ventilator flow sheet. So you might hear me talk about vent flow sheets, and that's what we'll be talking about here. All right, so the ventilator system checks are performed if an acute change occurs in the condition, right? So obviously we have a patient whose lung compliance changes, they desaturate, and we have to go up on their oxygen settings. We have to go up on their PEEP or their FiO2. Should we do another check? Yes, we should, right? There's an acute change that occurred, and what was the subsequent result of that? So well, the patient had acute change in desaturation. The subsequent result was on the PEEP FiO2 scale to go up to a PEEP of 12, right? So then we do a full assessment from there, right? So then we need to do it as soon as possible after we do that to show that intervention and then how the patient responded to our intervention. What if a patient returns after testing? Let's say they go to a CAT scan, they go to interventional radiology, they go have a procedure performed in the OR, and they come back. Well, we should do a vent assessment when they come back, even though they're not scheduled to have one yet, just to show where they were at when they got back. And then whenever the ventilator's performance is questionable, once again, are you concerned that you have odd alarms going off? Are you concerned that you don't have as good chest rise? Go ahead and do a vent assessment. See where you're at, because it's a way to check and look at some of the different systems that are going on and how the patient's interacting. You might be able to check something pretty early on and find it and fix it pretty early. All right, points to emphasize regarding the ventilator check, right? We need to make sure that it's data that's relative or relevant to the patient's ventilator system check on the appropriate form. So make sure it has to do with that situation with that patient. Your personal observations are not your personal observations. They're observations of what's going on with the patient in the ventilator, right? So this is not for you to start writing your own novel. This is for you to paint a picture of what's going on between the patient and the ventilator and how that patient is looking currently, right? So make sure it's relevant to that patient ventilator check. It should include observations of the setting at the time of the check, right? So how's the patient doing? Are they looking like they're air hungry? Is there evidence of things like that? Is there auto PEEP and air trapping, right? We need to look at these things. So here is a typical form. This form was provided in your book. The form usually includes a lot of spaces for entering current information about patient measurements and vent parameters. So there should be simple things like date and time, the mode of ventilation, pressure, volume, if it's a full support, partial support, spontaneous, if it is what their minute ventilation is, their respiratory rate, their tidal volume, whether they're in pressure volume ventilation, their peak inspiratory pressures, how much pressure it takes to deliver that breath, what their plateau pressure is, their compliance, their air resistance, their FiO2, the temperature of the inspired gas, good humidity, I to E ratio, inspiratory to expiratory ratio, their CPAP or PEEP level, right? IPAP versus EPAP if they're on non-invasive, what their ABG results were. A to A gradient is always a good way, or PF ratio is another way. So A to A gradient, PF ratio, both of those are looking at diffusion. So either of those are appropriate. The vital capacity, especially if we're looking to wean or look at the strength of the patient, vital capacity and a MIP are great, especially if we're looking at things like weaning or trying to see where that patient's muscle status currently is. Vital signs, what their blood pressure and heart rate, all those things are. What the alarm settings are, especially if the alarms are appropriate or not, we need to record those. So things that we're typically looking at, obviously volumes, pressures are going to be a big thing no matter which mode we're in. Temperature of the gas, vital signs, FiO2, each ventilator check. So things that we need to make sure that are in there, volumes, pressures, temperature, vital signs, FiO2. during each ventilator system check. And that's on the end of summary documentation on this video. Most intensive care ventilators have oxygen analyzers that will provide continuous monitoring of how much FiO2 the patient's getting. In cases where the continuous FiO2 measurements are not available on a ventilator, you might have to intermittently get FiO2 measurements on those patients as well. Most ventilators have an oxygen analyzer built into them, so you won't have to worry about this. But if it doesn't, then you might have to obtain one on your own. So the FiO2 should be continuously monitored. However, for infants that receive ventilation, make sure you regularly check to ensure that FiO2 has been set appropriately, because they're very prone to oxidative lung injury. Not only that, oxidative lung injury, but oxidative eye injury with retinopathy of prematurity. Other things we want to look at, ABGs, what their shunt fraction's doing, and there's an 8A gradient for every 100 in the 8A gradient. That's, you can go up by 5% on their shunt fraction. We'll talk about that later. PF ratio is going to be one of our big things to look at. Diffusion. Is their diffusion getting better or worse? If their diffusion's getting worse, that might tell us what's happening with that disease process. Despite the importance of regular, accurate documentation, a lot of respiratory therapy departments do not follow specific guidelines for patient ventilator checks, unfortunately. And so the big thing here is, how are you going to practice when you're out there? You might see people just sort of write down numbers here and there or copy things over from the last time they were in there. That doesn't mean it's the right way to do it. That just means that that's what that person does. What you are is who you are when no one's around, right? So I want you to be that ethical person when no one's around. If it was you or a loved one on the ventilator, who would you want taking care of you, and how would you want them to treat you, right? So compassion first is the way to go. And when we're looking at this, making sure you're thorough, because that thoroughness not only helps the team see the appropriate interventions that needs to be done, but it helps us understand where the patient's at, where they're going as well. So big things, make sure that there's orders for mechanical vent settings that are in place somewhere, somehow, some way. Even if they're under a ventilator protocol, there's at least a physician order for ventilator protocol, right? And then make sure it includes a brief narrative of your observations on the response to mechanical ventilation at the time of the check. No work of breathing noted, right? Versus, hey, work of breathing noted, care team notified of this, right? So if you do see something out of place, skin is mottled, pale, so on and so forth, then you chart not only that you've seen that, but that you made the team aware. No, don't just chart you made the team aware, but actually go and tell other parts of the team, right? Go to the physician, go to the nurse, go to those people, the other people that are part of that care team, and explain to them your observations, and right, and then maybe that we can create a plan, because you might be the first one to make that observation. You don't know, right? These patients can be very, very sick, right? So if you do see something out of normal, like they're mottled, like they're pale and dusky, right? That's a good time to not only just chart that, but to bring that up to the care team and note that you told someone about it. Because if you noted it and you didn't tell anyone about it, it's kind of a big deal, right? If you note it and then you notified the care team of it, then that sort of takes that some of that onus off of you of not telling someone, right? All right, the first 30 minutes. So immediately after each patient is connected to the ventilator, you should perform auscultation of the chest. You should listen to their lung sounds to make sure they have adequate delivery and proper placement of the the endotracheal tube. So once we intubate, you need to listen to their chest, right? Now, we should listen to the stomach first. We talked about that in critical care techniques. Listen for stomach gurgling, right, with each breath. That's a sign you're probably not in the chest. But if you listen to the chest, you should listen for equal breath sounds on both sides, right? If it's uneven, it could be one of two things, either a pneumothorax or the tube could be main stemmed, right? So we need to auscultate the patient's chest to make sure they have adequate volume delivery, proper placement of the tube. The next thing is going to be looking at their vital signs. we're going to see how they're interacting with it. Especially if the tube is sitting right on top of the carina, their blood pressure and heart rate could be dropping. They could be braiding down because remember, parasympathetic stimulation or vagal stimulation is at the carina. So if the tube's sitting on there or stimulating the carina, then we could easily see that type of thing going on. So should you be paying attention to their vital signs? Absolutely, right? We're talking life support machine here. Vital signs are going to be vital, right? So that's going to be a key thing you have to look at. So heart rate and blood pressure, because ventilation could easily impact those as well. If I give too much PEEP, if I give too much median airway pressure, if I give too big of volumes, can they impact blood pressure negatively? Absolutely, they can decrease blood pressure and cause low perfusion to organs and low perfusion to the brain as well with vena cava restriction. So we got to look at that. Another thing besides looking at vital signs are the patient's alarms. The apnea alarm, low pressure alarm, low tidal volume alarm, high pressure alarm. Make sure that not only they're active, but they're appropriate for the patient. Now, if you're like, I don't remember what alarms are appropriate, please go back to that other lecture where I talk about the appropriate alarm settings. But for now, just make sure that you're checking all those things. So activate the alarms, right? That's where we're at here. So make sure those alarms are active. An ABG should be obtained around 15 to 20 minutes, and that's where we're at this. Obtain an ABG 15 to 20 minutes after mechanical ventilation is initiated for evaluation of the effectiveness of ventilation and oxygenation. It's your gold standard, ventilation oxygenation. So 15 to 20 minutes is allowing time for the ventilator to equilibrate, allowing for the lung tissue to equilibrate, allowing for the ventilator to take its time to have where they're going to be at baseline. So that's why you wait around 15 to 20 minutes for that. And if you haven't done one right after intubation, you probably want to make sure you get a chest x-ray to confirm proper placement of the ET tube. Not necessarily if it's in the esophagus versus trachea, but how far above the carina is it, right? 3 to 6 centimeters is roughly what we're looking at for the adult, or in a neonate between the thoracic inlet and above the carina. Anywhere in between there is okay, right? We should look at other things too besides proper placement, lab tests, right, as well, besides the ABG. So we could be looking at their CBC, we could be looking at their electrolytes, we could be looking at a bunch of other things too. So it's a good thing to see where the big picture is on that patient. A key points here, that's the perform lab test part. The key points here is to understand and remember that positive pressure ventilation can reduce venous return to the heart, right? We're restricting the vena cava with all that positive thoracic pressure. So your cardiac output could go down, your blood pressure could go down. As a result, your heart rate probably goes up. So if you see blood pressure go down and heart rate go up, odds are that that PEEP change that you just went up on is causing a restriction and causing a reduction in that cardiac output without even having a cardiac output monitor in place. You could see that. If you had an end-tidal CO2 in place as well, right, bonus material time, if you had end-tidal CO2 in place and you go in and increase someone's PEEP level and you see the heart rate increase, blood pressure decrease, and end-tidal CO2 decrease, then there's a sign that you just caused venous return to be restricted, and therefore that's why the heart rate's going up. Because remember, heart rate times stroke volume equals cardiac output, and if heart rate goes up, it's usually to compensate for a lower stroke volume. So that's where end-tidal CO2 can actually be one of your first signs. Hey, what I just did actually caused a dead space issue. I caused a hemodynamic restriction issue. The patient did that. Was that a positive response to that situation? Probably not. So we might have to go back down on that mean airway pressure or that PEEP setting. So once the patient assessment, once we have everything sort of good to go, and it shows that the patient is stable, then you should perform your first vent check as well. So make sure everything's looking good. Once the patient's everything looks good, go ahead and do that initial check. All right, so when we're looking at this, The mode is one of the first things that we do. So when we're doing this, we need to say, hey, what mode did we put the patient in? That's going to be the big thing, because we would need to know how their breath is being delivered, because it's kind of an important thing. So the mode could be volume controlled CMV, volume controlled continuous mandatory ventilation. So that means the patient's getting full support and we're using volume to dose the breath, how big the breath they're getting. Or it could be pressure controlled continuous mandatory ventilation, where every breath is going to be the same size breath, but instead of using volume to dose it, we're using pressure to dose it. We're using pressure to deliver that breath. We could be using things like intermittent mandatory ventilation. You might see that more common in your neonates. And that one you could use either pressure control or volume control with it. So, and then even in that one, you can use it with or without pressure support. I've seen them use the SIMV or IMV in patients that are neuro that are hyperventilating, and we're trying to use that to reduce their hyperventilation. There are other modes like pressure regulated volume control. Pressure regulated volume control uses pressure to deliver the breath, and it has a targeted tidal volume. So in theory, it's going to use the lowest pressure to deliver that target tidal volume. So it's a combination of volume, specific event parameters to help control the ABG more appropriately while maintaining lower pressures to deliver that breath. There's advantages and disadvantages, and this is not the lecture for that, but understand with every mode there's advantages and different disadvantages. There's another mode out there called airway pressure release ventilation, or APRV. If the patient's in that, that would be a mode that you would put in there. Another mode that you could see is pressure support ventilation, volume support ventilation, CPAP, right, where we just do CPAP, no pressure support. So that means it's unsupported spontaneous ventilation. So all those, the pressure support, volume support, CPAP, are spontaneous modes where the patient does all that work. We might help to overcome the ET tube with a pressure support of 5, but that's about it. Or what if we put the patient non-invasive? What if you do bi-level positive airway pressure? Or even non-invasive ventilation, right? So those would be the modes, right? Examples of different modes that you would write there. The next one here is sensitivity, right? So sensitivity is the next one that we're looking at here. If a patient triggered mode is used, right, that means the patient is initiated by the inspiration is initiated by the patient's effort. The pressure or flow required to trigger that ventilation should be checked. So we're going to record a sensitivity or trigger setting. It should be no more than -1 to 2 centimeters of water pressure if it's in a pressure trigger setting, right? If the ventilator is flow triggered, if the breath is flow triggered, it should be set so that the ventilator will trigger at a flow change of initially 2 to 3 liters per minute. So 2 to 3 liters per minute for your flow trigger are a good place to start. Now, can we change those based upon what's going on with the interaction? Yes, but this is our first check. So this is where we're giving them initial settings, and we can customize it from there. But usually 2 to 3 liters a minute is a good place to start for a flow trigger. If the vent is checked and we see auto triggering where it's cycling a breath, cycling a breath, cycling a breath, right? And it's too sensitive, then we can adjust that as needed, where we can make it harder for that breath to be triggered and therefore avoid hyperventilating the patient mechanically. So we can always make adjustments as needed. When there's auto PEEP present, we can make adjustments as needed because they might have difficulty triggering the breath, so we might have to make it more sensitive for those auto PEEP patients, right? If the presence of auto PEEP is there and they're using accessory muscles and they're working hard to breathe, the ventilator graphic might show that they have the failure of the flow rate to return back to 0. And so that shows they have auto PEEP. So go back to the graphics presentation. I have some examples in there. How are we going to fix this? Well, this means I'm going to increase my flow rate to help reduce my inspiratory time, right? And then therefore I could reduce the rate In theory, I could also reduce the tidal volume as well. So all those things will help create a longer expiratory time, which should help as well. Um, Changing modes as well might help with more spontaneous breaths if they're air stacking, right? If they're auto peeping quite a bit. So I can go from a CMV to a IMV mode, right? SIMV, or I could go to spontaneous mode if it's appropriate, right? But it's important to recognize that we might not always be able to eliminate things like auto peep. It might still be there. Especially with patients that have high airway resistance and high airway closure, right? We're going to have to understand we might have some just there at baseline. It's not that you can get rid of all of it just with your event setting changes. Other things to look at in addition of extrinsic PEEP is making the trigger easier, like I was saying. If extrinsic PEEP is increased progressively until they're using accessory muscles, or in other words, I can increase my PEEP progressively until their use of accessory muscles diminishes, until PIP and plat, or until their peak and their plats start to rise as well. So these are things that I can look at to change. All right, so let's look at tidal volume, rate, and minute ventilation, which is this next bullet point here. Tidal volume, frequency, and minute ventilation are typically displayed digitally on the front panel of the ventilator. So you're going to have some way that the ventilator will display that. Now, different ones have their screen set up differently, but most ventilators will display these. The set tidal volume, especially for volume targeted ventilation, and then they'll have something like exhaled tidal volume as well, right? So they'll give you not only what's being delivered, but what the patient's exhaling. So these microprocessor controlled ventilators usually provide very reliable flow and pressure monitoring. So that's one of the good things that we can do there. But if we don't, you can still measure tidal volume on a respirometer, like a Wright's respirometer, if they're doing minute ventilation. And then you're watching a clock with a sweeping hand and looking at their minute ventilation, dividing by the rate, and that gives you their average tidal volume. That was traditionally done with older ventilators, like when we set up the IPPV as a ventilator. But it can also be used to verify digital readouts. So if you think that the machine is inappropriate or not calibrated appropriately, the patient's still safe, in theory, you could use this to confirm. You can use that to confirm what the ventilator is saying the patient's doing. So let's talk about this next bullet point, correcting tubing compliance. So it's usually automatic on our microprocessor controlled ventilators. So when we do a short self-test, when you set up the ventilator with the circuit, usually you'll do a self-test that looks at the circuit compliance, and it automatically adjusts for the volume loss within the circuit because the tubing compliance or the compressible volume. So it talks about more of this in your chapter 6 of your book, but most ventilator circuit tubing compliance is about 1.5 to 2.5 milliliters per centimeter of water, which means the more pressure it uses to deliver the breath, the more volume change there is, which means the patient could not be getting the appropriate tidal volume that we want them to get. So that's what compressible volume is looking at, or correcting for tubing compliance. Since we're losing a tidal volume due to the compliance of the circuit, we're robbing the patient of the breath size that's appropriate for them. So that's where that looks at. Most modern ventilators, you won't have to look at this because we've done that with that short self-test ahead of time. So correcting for tubing compliance, we can always practice some of that as well. But most of them do not require you to calculate tubing compliance because these machines automatically compensate for this. So ventilators that perform this function typically increase the delivered tidal volume. So the set volume is the amount provided to the patient. So if I set it for 500 mLs on my modern ventilator, then the patient's getting 500 mLs, right? They're not actually getting 450 because they're losing some of that, right? So they're actually getting what I'm set. The machine, even though it says we're delivering 500 mLs, it might actually be delivering 550, but understanding that 50 of that actually never got delivered to the patient because of the circuit compliance. The circuit expands and collapses with the breath delivery. So most of the machines we don't have to calibrate for that, right? Kind of a cool feature there. So that digital readout will usually indicate the tidal volume actually delivered to the patient's airway. But older ventilators, if you ever have to bring those out of retirement or into operation, you can get a set value for the tubing compliance, and we can always practice that as well. But you're looking at compensating for the volume loss due to tubing compliance. The next one here is alveolar ventilation. Monitoring alveolar ventilation has declined in popularity. There's a lot of acute care facilities that don't include this on their flow sheet. So guess what? No one's following it. So therefore, if it's out of sight, it's out of mind, right? Unfortunately, it comes in very, very handy when you go to ARDS or low tidal volume strategies. When you're going to these very low tidal volume strategies, inline HMEs can be a big issue. And so what we're going to look at with these patients is the lower the tidal volume we go, things like HMEs, heat moisture exchangers, closed suction systems, other circuit adapters, equipment like MDI adapters can add what's called mechanical dead space to the ventilator and affect their dead space to tidal volume ratio. In other words, the patient's not getting an appropriate tidal volume because they're being robbed of it by the HME, by the adapters, by all that stuff that's in line. So knowledge of the effective dead space on alveolar minute ventilation can particularly be important, especially in infants and children, right? Or even smaller adults or adults that are in ARDS where we're using tidal volumes that are 4 mLs per kilo. So looking at their dead space and charting dead space is something that we did at the facility I worked at because of a lot of reasons. We had spinal cord injury patients where we'd have to use very large tidal volumes, but we had also have to use very large dead spaces to make sure we didn't hyperventilate them, right? So we always charted the amount of dead space there. Or even when someone went into ARDS, when they went to a low tidal volume like a 4 ml per kilo strategy, 4 to 6 mLs, then we'd have to chart the amount of dead space. And the advantage there is then that communicates, hey, we can actually retain less CO2 if we get rid of some of that. Some of that's not essential. Let's get rid of it if it's not essential. All right, so that's what we're looking at here. So things that we're looking at are anatomical dead space that the patient naturally has, which is roughly 1 ml per kilo of ideal or predicted body weight. And then the other factor that we have here is the added mechanical dead space. So that would be things like the Ballard. Anything past the Y of the circuit is mechanical dead space. So normal anatomical dead space, 1 ml per kilo, 1 ml per pound, of ideal body weight. And we're bypassing the upper airway with an artificial airway, right? So when we bypass the oral pharynx, the nasal pharynx, and then the top part of the trachea, we're actually reducing anatomical dead space by about half. Right, that's pretty significant. So they're going to have more effective ventilation automatically when we bypass that upper airway. So using a Y connector, flex tubing between the Y connector, the ET tube, and HME, it adds mechanical dead space. So yes, we are adding dead space to it, but ultimately we might be about the same as them breathing through their oropharynx with how much we're adding to it. But because HMEs and other adapters add to mechanical dead space, the volume of these devices along with the patient's anatomical dead space must be subtracted from the tidal volume. So the more mechanical dead space there is, the more that likely that the patient is not getting their set tidal volume that we're hoping they're getting, right? So when we're looking at the tidal volume, yeah, it's still delivering it to their lungs, but how much of that is participating in alveolar ventilation, right? How much of it is actually participating in gas exchange? Minute ventilation is great. It's how much gas is going in and out of the lungs, but that includes the conducting airways where there's no CO2 and O2 exchange. Alveolar minute ventilation is where there's CO2 and O2 exchange, and that's what we care about. So adding dead space decreases alveolar minute ventilation. It decreases the ability and hinders the ability for CO2 and O2 to exchange. So it's not just about regular big minute ventilation, which includes conducting airways. It's also about alveolar minute ventilation, which is your actual exchange of CO2 and O2, the functional part of your big minute ventilation. So, and this is an example problem here. If we have a 150-pound adult patient and their tidal volume is 500 mLs, and we add a mechanical dead space of 100, the alveolar ventilation would be, right, 250, right, because we're subtracting, right? So we're having a lot of dead space here. So the functional of what's getting into their bloodstream and getting out of their bloodstream decreases when we're adding all this dead space, right? So during mechanical ventilation, we take the number of breaths counted by 1 minute, and then we're going to look at their anatomical or mechanical dead space. So tidal volume minus anatomical minus added dead space, and that's what you're seeing here. Tidal volume minus anatomical, right? Do you guys see this? Tidal volume minus anatomical minus added mechanical dead space. So that's what we're looking at here. And so we're taking those out. So this is a patient that's on volume controlled intermittent. And then the rate must be calculated separately from the patient. So we take the rate that's separately from the patient. So we take that times the rate to look at alveolar ventilation. So that's what we're looking at here. And there's some examples in your reading material as well. But the big thing here is to understand the more dead space, the concept, right? The big thing here, the more dead space we're adding to that patient, especially the lower tidal volumes we go, the more significant effects it could have on our blood gas becoming more and more hypercarbic. So that's why you might see them trim ET tubes. You might see them get rid of a bunch of dead space in those patients on very low tidal volume strategies to help do that, or change from an HME to a humidified circuit. All right, let's look at monitoring airway pressures. So monitoring airway pressures, here we're looking at PIP, plateau, our set pressure or trans airway pressure, and our end expiratory pressure, some people call it PEEP, or our baseline, right? It could be positive end expiratory pressure, it could be NEEP or negative end expiratory pressure. It could be ZEEP, especially there's APRV strategies that use ZEEP or zero end expiratory pressures. But when we're looking at this is an airway pressure waveform. And so this is just an example of airway pressure waveform used during volume-controlled ventilation. At end inspiratory, a breath hold is applied, and then we can also do one at end expiratory hold, right? So we want to do an end inspiratory breath hold, which is called an inspiratory pause maneuver, and then as well as an end expiratory hold that's applied. And what we're looking here is we're going to be looking at, when we do these maneuvers, plateau pressure for end inspiratory. And then at end expiratory, auto PEEP, right? We're going to look at how much auto PEEP there is. So here, there's a difference between our PIP here. So here you're seeing the peak inspiratory pressure, right? Here's your PIP up here, and then here's a plateau pressure down there, right? So when we're looking at this, the difference between the peak inspiratory pressure and the plateau pressure is what's called the trans airway pressure. So the gradient between your PIP and your plateau is your trans airway pressure, right? There's a trans airway pressure. So this is produced by the interaction of the set flow and airway resistance. So in other words, the big thing that makes it change would be the patient's airway resistance or you changing the flow through the ventilator circuit. So those are the two factors that can make that change, right? So the tidal volume is the product of the pressure difference between plateau and PEEP. In total PEEP, right? Total PEEP would be including auto PEEP, and then looking at your lung compliance. So PIP and plateau are pretty important. So in inspiratory pause, we'll look at plateau. And plateau is another way of looking at your alveolar pressure. It's actually looking at elastance because it's saying how much pressure with the inspiratory pause, how much back pressure there is, how much elastance there is. The higher the elastance, the lower the compliance. That's why a plateau pressure that keeps going up in numerical value actually means their compliance is becoming lower and lower and lower, right? So we'll use it as a way. Elastance is the inverse of compliance. So that means that the higher the plateau goes, the lower your compliance is. right? The higher the plateau goes, the lower your compliance is, roughly. Very simplified statement. Obviously, understand there's more detail that goes in there, but that's a good starting point, right? Until you get to the more detail of it. But the higher the plateau, the lower the compliance traditionally. So monitoring the airway pressures is going to be very key, no matter what mode we're in, because all positive pressure ventilators have a pressure monitor or display that continuously shows the upper airway pressure. The pressure monitor is probably the most accurate when it shows pressures measured near the patient's upper airway. So when you have a ventilator, I think the Hamilton has them on their ventilators where it's a calibrating sensor, a calibrated sensor that's close to the airway that we calibrate when we start up that machine. And so it's there instead of all the way back at the circuit, back at the ventilator. So it's proximal to the patient rather than proximal to the ventilator. So that's where it's going to be most accurate. And in fact, in neonate volume ventilation, that's where we also look at those guys as well, having that sensor proximal to the baby, which gives us this most accurate, because then we don't have to worry about the expiratory line having enough flow through it to make sure we're reading accurate pressures and volumes. So proximal pressures are usually obtained by connecting a monitor tubing or plastic Y connector there to the circuit. But like I said, some ventilators like the Hamiltons I know will have the proximal sensors. Others might have that adapter ability as well. But what you're doing here is you're trying to look at the circuit pressure before it goes through the circuit. A lot of these values are usually not measured at the proximal airway, but ICU ventilators in general for adult patients are very accurate and very clinically useful when you're looking at it where it measures it back at the ventilator, proximal to the ventilator, or the expiratory side of the ventilator. Still very, very accurate, but in theory, the most accurate is going to be where it's proximal to the airway. Pressure monitoring will allow the clinician to assess pressure delivery to the upper airway. How much pressure are we delivering to the endotracheal tube, right? And then how minimal that pressure is as well, so we can detect if there's any leak. And we can see that high pressure limits do not exceed what the mechanical ventilator is telling us. So we could use these pressure sensors to actually verify our ventilator readings if we have reason to doubt it. But intermittent readings of PIP and plateau, set pressure for pressure targeted modes or pressure support modes, trans airway pressure, which is peak airway pressure minus plateau pressure. We could look at mean airway pressure. We could look at end expiratory pressure. They all provide very valuable information about that patient's condition. So let's start with PIP. All right, the big one, the PIP or peak airway pressure, right? Synonyms. I already circled it there. There you have PIP and plateau circled, but PIP is the one that we'll be talking about here. PIP is a synonym for peak airway pressure, right? Which is the highest pressure observed during inspiration. It can be used to calculate dynamic compliance, right? A fairly consistent tidal volume with an increasing peak pressure might indicate that their compliance is going down, or it could also mean that the airway resistance is increasing. How do we know which one it is? You have to look at both values, right? So conversely, a declining PIP, if their peak airway pressure starts going down, let's say it's 30 and now it's 28, then it's 25, then it's 22, right? So a declining PIP might indicate that there's a leak, or might be a sign that their compliance is improving, or maybe their airway resistance is getting better because all the nebulizers and steroids are working, right? So we got to look at our PIP. That's going to be very helpful to tell us about lung mechanics. Plateau pressure. Plateau pressure can be obtained using the inspiratory pause control. Usually it's about 0.5 to 1.5 seconds, and then it's read during no gas flow rate. So traditionally the plateau is determined where the ventilator occludes the expiratory part or port of the inspiration, and then we're looking at the manometer. If after the PIP is reached, the manometer shows a drop of a few centimeters from the peak, then it stays in that position then that's that static pressure. So in theory, you could still do it manually, right? It is important to remember that plateau cannot be measured accurately if the patient's actively breathing. So if they're breathing 40, 60 times a minute, right? I'm just giving you numbers, right? If they're actively breathing during that measurement, it's not accurate, right? Or the machine nowadays may say unable to perform, right? So if the patient's actively breathing, you may not be able to get a plateau pressure, right? So that's something to pay attention to. So it cannot be measured accurately if the patient makes active respiratory efforts. If they have a high respiratory rate or resists their inspiratory tidal volume pause, it makes it difficult, but not impossible, to obtain on spontaneous breathing individuals as well. Plateau is most often used to calculate static compliance, which reflects the elastic recoil of the alveoli in the thoracic cage. So if a patient's current practice really strongly recommends keeping the plateau below 30 centimeters of water. Below 30 centimeters of water, that's a big thing. Usually, if their plateau exceeds 30 centimeters of water pressure, we have to do certain things like decrease tidal volume, right, to make sure we're having safe ventilating pressures and not destroying lung tissue. Notice that during either pressure or volume ventilation, if the condition of no gas flow occurs at end inspiration, the corresponding the pressure time curve usually indicates plateau pressure. So we could actually see this on a graphic as well. All right, let's go to the third bullet point here, the set pressure on this third bullet point. During pressure control CMV, pressure control IMV, pressure support ventilation, you will set a target pressure to be delivered to the patient. So this usually includes a separate piece on the ventilator flow sheet for entering that target pressure that you'll only use when you have pressure targeted modes. So that's something that you'll set there. Trans-airway pressure is that next bullet point. Trans-airway pressure, and there's the equation right there, is your PIP minus your plateau pressure. So the difference between PIP and plat readings is the trans-airway pressure. It's the amount of pressure required to overcome the airway resistance, right? So how do I calculate airway resistance? I'm glad you asked. You're like, I didn't ask, Derek. Why are you giving me calculations, right? Because they're awesome and they represent physiology and they help you take care of patients more appropriately. So airway resistance is the trans-airway pressure, PTA, over flow rate in liters per second. Remember, flow has to be in liters per second. So most mechanical ventilators, when you set flow, it's in liters per minute. Yes. So that means you have to take the flow rate divided by 60, then do the PTA over that flow rate in liters per second. So the PTA includes the resistance of the ET tube as well. If I use a really tiny tube for a big person, right, what happens to air resistance? It's really high. Imagine trying to drink a milkshake through a little coffee straw, right? A lot of resistance, right? A lot of flow trying to go through a very tiny tube, right? Air resistance will go up if I use too small of a tube. If I have bronchospasm, a lot of flow trying to go through a very small tube, right? So air resistance is going to be a big issue there. So when we're looking at this, ET tube is a factor that we have to take into effect here. The higher than expected difference between PIP and plateau usually suggests an increase in air resistance, right? Most of the time, patients with increased air resistance require your attention. It could be suctioning from secretions if there's secretions stuck on the tube or inside the tube. Maybe the patient is biting on the tube or the tube is kinked. That can happen. I've seen it where the tube gets pulled out slightly and the cuff is herniated over the tip of the tube a little bit. There could be mucosal edema, bronchospasms, both, right, especially with pulmonary edema. It could be increased if the heat-moisture exchanger is partially occluded with moisture or secretions, right? So there's a lot of factors that go in here. So looking at the airway resistance and what could have caused it, it can be very important in making sure that you can take care of the patient in a timely manner. All right, mean airway pressure. Mean airway pressures. Usually the ventilator will display what their mean airway pressure is. they will automatically calculate this, right? But mean airway pressure is affected by PEEP, or end expiratory pressure, and what's called the duty cycle. Insert snickering here. I'm sure some of you are, right? And the duty cycle is I time over total cycle time, right? And that's going to be one of your big thing, I time over total cycle time. And then your frequency. Inspiratory flow patterns and modes can influence this. So one of the things that we have to look at is monitoring mean airway pressure can be useful when looking at the benefits and side effects of positive pressure ventilation, because it closely parallels alveolar mean pressure, right? Alveolar mean pressure. So when we're looking at this, if I'm trying to improve tissue oxygenation, and let's say a patient has a lot of atelectasis on their chest x-ray, right? And one of the things I can do is increase their I time, increase their total cycle time, right? I can increase these things to help effectively recruit alveoli and improve them with just mean airway pressure instead of increasing tidal volume, right? So if I increase PEEP and increase mean airway pressure, then that might actually help optimize alveolar pressure, which helps with diffusion of gas into the bloodstream. Right, so it might help with tissue oxygenation. It might tell me about my lung volumes and my cardiac output. If I have too high of mean airway pressures and I see the heart rate really high and I see their end-tidal CO2 really low, then that could be a sign I have too much mean airway pressure for that patient. So it gives us a lot of valuable information. All right, so mean airway pressure, not on that bullet point list, but something we need to talk about. So most of the times you don't directly control mean airway pressure unless it's a high frequency oscillating ventilator, but it's indirectly, right, put by all the settings that we talked about there, your duty cycle, as well as your PEEP, so on and so forth, your frequency and stuff. So the depth of the breath. One of the things that here we have to look at with end expiratory pressure, it is the lowest pressure measured during the expiratory phase of a breath. So end expiratory pressure should usually be above atmospheric pressure, and if it is, it's called PEEP or CPAP. Right, and expiratory pressure is also elevated if there's auto-peeping occurring, which is what you see in this graph. Here you see PEEP on the left-hand side, and then here you see auto-peep. You can see how this auto-peep is much higher than the baseline, right? So that means the patient isn't usually completely exhaling all that gas, right? So how do we know if this patient has auto-peeping? Well, one of the things we can do is an expiratory pause maneuver, and that will measure auto-peep. So most ventilators have a control for this. The expiratory pause usually lasts for about a half second. Now, can it go for a little bit longer? Absolutely. But traditionally, with the auto-peep, we're looking at about a half second. So when we're looking at this, you can have it go up to 1.5 seconds. But, and then even some vents can allow you to go up to 15 to 20 seconds. I don't know what patient's going to tolerate that, but it will allow you to. Just like plateau measurements, end expiratory pressure readings or expiratory pauses is only accurate if the patient is not actively breathing. So if the patient is actively breathing during an inspiratory pause maneuver, not accurate. They're actively breathing during an expiratory pause maneuver, not accurate. Unable to obtain is what you're recording. Unable to obtain due to patient effort. Sometimes you can get PEEP total, which is the sum of the PEEP that the patient has as well as their auto PEEP, right? So this is recorded on the flow sheet as PEEP total. So that means, hey, I have a PEEP set at 5, but their total PEEP is 8, right? Because the PEEP is air trapping 2 centimeters of water, right? So it's important to understand that PEEP total should be subtracted from the plateau pressure to calculate the static compliance. And we've already gone over this calculation before. And then from PIP to calculate dynamic compliance. So an airway pressure slightly greater than 0 can occur at the upper airway during exhalation if a constant gas flow is moving through the circuit. So this constant gas flow is referred to as what's called bias flow. Most ventilators will have some form of bias flow or base flow. It's used to help the ventilator detect flow changes during exhalation that allow for triggering. So you'll probably have bias flow through the circuit no matter what. Most modern ventilators, bias flow only occurs at the end of exhalation, right? So there's no resistance to flows exist at the beginning of exhalation. So it only does it later on, right? And usually most microprocessor ventilators will correct for bias flow, which doesn't even appear on the graphic, so you won't even see that on the pressure time or flow time curves. But you can see with some of the older ventilators like the LTV 1000, right, that one had a constant bias flow of gas during exhalation at 10 liters a minute. And then when we're looking at that, that could change things, right? So traditionally, the presence of bias flow is usually not clinically significant and does not cause an increased resistance to exhalation, except for small infants or on those patients, the small infants, it can really increase their work of breathing. All right, let's talk about monitoring airway pressure limits and alarms. Alarms are pretty important. Make sure the alarms are functional. That's something that we're going to check every time we go in and see that patient. So audible and visual alarms are activated if the PIP exceeds the set limit. So usually about 10 centimeters of water above the PIP, right? 10 centimeters above the PIP is where you're going to set this. Activation of the high pressure limit alarm ends inspiration. It'll cut the breath off. It'll terminate the breath to avoid causing damage to the lung. Some newer ventilators have an alarm delay that allows the limit to be exceeded for 2 to 3 breaths before the audible part of the alarm is activated. So sometimes that can help with things like alarm fatigue and patient anxiety, but it is worth noting that in instances where the pressure limit is exceeded, the breath will still end and the flow to the patient stops for that breath. So it's still, even though it may not alarm right away, it stops the breath. It's still safe for the patient, but the alarm will just wait a couple of times. So let's say they did a cough. Well, instead of each time they cough, it goes off. Hey, they cough and it doesn't go off, and then the next breath they're not coughing, then it doesn't cause that alarm fatigue, right? So you might have that on some ventilators too. It is important to recognize that although high pressure alarms frequently are activated when the patient coughs, it might also indicate that there's an increase in airway resistance or their compliance is dropping. So as I mentioned earlier, increases in airway resistance might signal that the patient's airway needs to be suctioned. They might have mucus in their ET tube or in their tracheostomy tube, or maybe they're having a bronchospasm as a result of a medication situation or something like that. What if the patient is biting down on the endotracheal tube, right? So decreased compliance is usually associated with a number of conditions like pulmonary edema, pneumonia, pleural effusion, pneumothorax, even hyperexpansion. If we have too much tidal volume, you can have high pressures as well. All right, what about low pressures, right? We just talked about high pressures. Low pressure alarms, audible and visual alarms alert you when the PIP falls below a designated setting. So this setting is usually 5 to 10 centimeters below that patient's average PIP. So let's say their average PIP is 10, right? Let's just say it's very low. So you have it set at 5. Right, 5 centimeters, 5 to 10 centimeters below that. Don't set it at 0, but 5 to 10 centimeters below that. They'll indicate that the pressure has fallen significantly, and it could be a leak involved in the circuit, right? There could be a leak involved with the circuit. So you got to be very careful if there's a leak in the circuit. The patient's being robbed of minute ventilation, robbed of tidal volume, robbed of pressures. So that could be a very serious situation very quickly. The most common cause of a leak is a disconnect from the ventilator, which can usually be seen pretty quickly. Remember, you always start the patient, work your way back. If a leak in the patient ventilator circuit is not obvious, then you should go ahead and manually ventilate the patient with a bag until you can identify the cause of the leak. So when in doubt, use that backup ventilator, the self-inflating or flow-inflating bag, depending on what type of patient you have there. So when you're checking the circuit for leaks, you want to look at the integrity of the ventilator circuit And this is part of every standard ventilator check that you go in to do, is not only looking at the patient interaction with the ventilator, but also things like, is the circuit and the alarms appropriate? Right, I want to look at that circuit. So checking that circuit is a pretty key thing. Is there water buildup in the circuit? Is there damage, visible damage or soiling in the circuit? Right. So when we're looking at the integrity of the circuit, that's a big thing to not forget about. You're looking for leaks, disconnected tubing, other problems. Usually the simplest way to look if there's a leak is to note whether their peak pressure and exhale tidal volumes are lower than where they were previously measured. So if my pips were 45, 40, 40, 40, 40, and then I go in to see that person and their peak airway pressure is 25, right? Odds are there might be a leak, right? There could be something like that. Or the tidal volume was 400, 400, 400, now it's 200, right? The odds are there could be a leak, right? The cuff could have been come up above the vocal cords, right? There could be a leak there. So peak airway pressures, exhale tidal volumes lower than the previous measurement. The volume time waveform can also be checked if it resembles what looks like an igloo. And here's the picture here. Do you see how that looks like a little igloo? Right, you see the little igloos, right? So if it looks like an igloo, the inspired tidal volume is greater than the exhaled tidal volume. So that is a sign of a leak, right? And then go look at the graphics presentation. I have you see different things in there as well. So to find a leak, you check the patient's airway by listening to the trachea with the stethoscope, because it could be a cuff leak. So that's one of the things that we'll look at. If the cuff or the tracheostomy tube, ET tube cuff is adequately inflated. If it's not adequately inflated, you could hear abnormal sounds, tracheal sounds, right, when there's a leak. So if you don't if you listen to the trachea and you don't hear a leak, then odds are that's not a cuff leak that you're looking for. So you just ruled out something pretty quick and easy to fix as well, right? You should check for leaks in the vent circuit, starting at the point where the circuit attaches to the ventilator outlet and working toward the exhalation valve, right? So before beginning this, it's prudent to make sure that the patient's being ventilated and oxygenated appropriately when you're doing this, right? So that's where you could either manually bag the patient and work your way through this. If the patient so therefore you might have to disconnect from the ventilator and manually ventilate or another person manually ventilate while you're trying to troubleshoot this. So the procedure for identifying origin of a leak is pretty straightforward. First, you start at the Y connector. Is it occluded? And the Y connector, you're going to occlude it, and you're going to look at the ventilator cycling. If the high pressure limit is not reached, if you occlude the end of the Y while the patient's disconnected, right, you're wearing gloves and all appropriate PPE, and you put your hand over the end of the circuit and you don't peak pressure and cycle it, then the leak is pretty significant. And so that could be a very, very bad sign. You might have to switch out the ventilator if you can't identify it. The second, the main inspiratory tubing on the distal side of the humidifier, the side farthest from the ventilator, is closed. So if the PIP alarm sounds, the leak does not exist in the humidifier. So a humidifier could be another source of the leak, right? It could be cracked, things like that. So that's something to look at. If the alarm doesn't sound, and the humidifier is not the point where we're looking at, then we're looking at the large bore expiratory line. We're looking at that and pitching and shutting that, and then the ventilator should be cycled. If the PIP alarm doesn't activate there, then the leak is located near the Y connector, right? So this technique works well for large leaks, but it's not very useful in very tiny, small leaks. Leaks most often occur around the humidifier or through humidifier water-fed lines, water traps, anywhere tubing connections join. So there are other possible sources like the closed suction catheters, the Ballards if you will, inline thermometers, end-tidal CO2 monitors, A normal leak might be around the ET tube if they're using minimum leak technique back from critical care is used to inflate the cup. But the leak that's associated with minimal leak technique usually is insignificant. Very little volume is lost in adult patients. Another thing to look for here is a chest tube may be another source of leaks. So pleural drainage systems is a likely source of a leak if it's detected on a volume time waveform, but cannot be found in the circuit. You've done everything in the circuit, you know it's not the circuit. Well, does this patient have a chest tube? You see the igloos, does this patient have a chest tube? And that could be a sign that that's just the chest tube, right? But all the volume measurements are the same, therefore the leak is constant. Note that the waveform causes the line to drop to baseline before another breath is delivered, right? Do you see that here? It drops to baseline. There we go, I just circled it, before the next breath is delivered. So that's something to pay attention to. Is this a chest tube leak, right? That's a great way, especially if you ruled out everything else. But that system leak can be pretty significant. It can be frustrating, but make sure that the patient is safely ventilated and oxygenated during this whole thing. If the patient's on pressure support ventilator, for example, during pressure support ventilation, inspiration is adjusted to end when flow falls below 5% of the peak inspiratory flow rate. So if there's a leak, and now it's on the servo, if there's a leak in the system, it could allow for the flow out of the circuit and make it where the patient's, it might not sense that for the patient. So most ventilators will have a backup time cycling where it says, hey, that breath is too long, they didn't cycle into exhalation, I'm going to end it. So it'll say an alarm like inspiratory time too long, inspiratory time too long. They're not sensing expiratory flow rate because there's a leak in the circuit. So a lot of times they'll alarm, right, that there's that it's there. So it's very important that no leak exists when we're looking at other things like looking at VDVT, oxygen consumption, like metabolic studies. That's going to be very important when we look at indirect telemetry as well. So in those situations where we're doing indirect telemetry where we can't have a leak, it might be make sure that we have a cuff that's sufficiently inflated to include the airway completely. So once we obtain our measurements, then we could go back to our MLT technique or reinflate it to their previous low pressure that they were once using. But a cuff leak might actually be there if the circuit leak's not there. So listen to the trachea. So you see a leak, listen to the trachea, right? Check the circuit, make sure the patient's adequately ventilated and oxygenated. And then if you can't find the source of the leak, check for a chest tube that could be there as well. And when in doubt, you could always switch out the ventilator as well. All right, so monitoring vital signs. So observing and recording vital signs are going to be very important every time we go in there. Heart rate, patient's temperature, circuit temperature, right? So temperature on both machine and the patient. Breathing rate, oxygen saturation measured by pulse oximetry, their physical appearance. That all these things really do help staff members evaluate for possible changes in their overall condition. In mechanically ventilated patients, rate, heart rate, pulse ox are usually continuously monitored. Temperature and arterial blood pressure also may be monitored continuously, but more often they're measured intermittently. It is important for you to remember that the alarms are activated only by critical changes. Moderate changes in vital signs during hourly, bi-hourly checks usually alert you if there's the possibility of hypoxemia or impending cardiovascular collapse, like the blood pressure and heart rate go down or end-tidal CO2 drop suddenly, or an infection, right? They start having elevated temperatures. So heart rate is going to be one of the first things that we'll look at here. Heart rate and ECG, usually they'll have an ECG on the monitor. It is a non-invasive way of continuously monitoring heart rate and their rhythm. All hospitalized patients receiving vent support must be continuously monitored with a 3-lead ECG. So the ECG provides minimum and maximum heart rate alarms, right? So they're both audible and visible. and therefore they can alert any of us if there's significant bradycardia or tachycardia that occurs. The leads are generally placed on the chest, one near each clavicle, and then one near the fourth intercostal space on the left mid-axillary line, so that should sound familiar. But it's important to place the leads so that their clearly discernible QRS complex can be displayed, so we can see what's going on. So a standard lead 2 configuration is typically used for monitoring your ICU patients. The ECG monitor is viewed or scanned by the computer for changes in heart rate and rhythm. So activation of an audible alarm will usually alert us to potentially dangerous events. So if the heart rate alarm simply indicates that the electrodes have been disconnected from the patients, or it could even signal that there's more critical event, like the patient has become disconnected to the ventilator, they have severe hypoxemia, hypercapnia, right, all that good stuff. So there are other factors that can affect heart rate. That includes pathological changes to the myocardium. So if they have an infarction, hypoxemia, and they're throwing PVCs, drug reactions to medications, especially medications that speed up or change blood pressure, slow down, decrease blood pressure, right? They could also be a response to anxiety, pain, and stress. So if we see some of those things that are pretty significant, you might need an initial 12-lead ECG when mechanical ventilation is initiated. Especially if there's an acute respiratory failure, just to get a baseline, or if anything changes significantly, you might have to obtain a 12-lead to verify, because it's only lead 2, a standard 2-lead configuration traditionally. Temperature. A patient's temperature can be measured by mouth, by ear, or axillary from the armpit, which is what we tend to use in the neonate world. Core temperature measurements typically are obtained using rectal, esophageal, or even pulmonary artery temperatures, but there are a number of factors that affect body temperature. Like hyperthermia can be caused by an infection. It can be caused by tissue necrosis, late-stage carcinoma, right? Hodgkin's disease, leukemia, metabolic abnormalities like hyperthyroidism. Low-grade fevers can be a result of accidental or surgical trauma. Atelectasis, right? Fever can be cause atelectasis. Fistulas, hematomas, foreign bodies. So your temperature can be controlled, go up by any number of things. What about hypothermia? Can result from metabolic diseases like hypothyroidism, central nervous system disorders, drugs, antidepressants, tricyclic antidepressants, or benzodiazepines. Benzodiazepines can easily decrease temperature. Other substances like alcohol, heroin, carbon monoxide can easily take the patient's temperature down as well. So understand it's a dynamic situation. There's a lot of factors. And the big thing is trying to figure out which one's causing it in this scenario. What about blood pressure? Patients' blood pressure should be checked intermittently with the stethoscope, so manually, or an automatic blood pressure cuff. So it can be measured continuously with indwelling arterial catheter with an arterial line, but invasive arterial pressure monitoring is very, very commonly used after open heart surgery for really critical patients. And it can give you continuous measurements of blood pressure. Arterial catheters, arterial lines, are usually placed in a peripheral vessel, such as the radial artery. And the big advantage of having it in the radial artery is that there's collateral circulation. So a modified Allen's test is something you should have learned, right, whenever the radial catheter is placed. And that shows us if the radial artery were to be somehow spasmed or to be blown for some reason or another, that there's still collateral circulation to the hand via the ulnar artery. Central venous pressure. Central venous pressure is an indwelling catheter usually placed in the superior vena cava, and the whole idea is to look at right atrial pressures, and it can be used to monitor CVP, which is helps tell us about myocardial function, right? We can see how well the heart is squeezing. It can tell us about fluid volume status in critically ill patients. CVP measurements really reflect right atrial pressure and right ventricular and diastolic pressure, how much pressure there is at the end of a squeeze, right? And therefore give us information about venous return to the heart, right? Venous return to the right side of the heart. Because it's elevated during positive pressure breath. In other words, you have usually when you breathe without artificial airways, you're using negative pressure to pull in. So the thoracic cage is actually negative. It actually sucks blood to the vena cava and pulls blood into the right atrium. But your CVP in theory would go down. But with positive pressure breath, you're squeezing the vena cava, which therefore would cause the central venous pressures to artificially be high because we're squeezing, right? Smaller container, increased pressure, right? So that's going to cause that pressure to be higher. So because CVP is elevated with positive pressure breathing, it's measured at end expiration, right, when the pressure in the thoracic cage is at its lowest volume. So CVP should be evaluated at end exhalation. CVP should be evaluated at end exhalation. CVP should be evaluated at end exhalation, right, when intrapleural pressure returns to normal or at its lowest value during the respiratory cycle. Pulmonary artery pressure, you won't see these too often out there, but you could still. The NVRC exam likes to call them balloon-tipped, flow-directed catheters, right? Or swan catheters is the other term that you'll see out there. It's connected to a monitor by a transducer. And they're used to typically monitor very hemodynamic, unstable, critically ill patients with severe cardiopulmonary issues. It can help with fluid management. You might see them post-op heart surgery patients. You might see them in your cath labs for diagnostic purposes as well. You may not see them too often. There's a lot of infection associated with these over the long term. So you don't see them as much, but you should be familiar with them. All right, physical examination. This one should go without saying, but got to cover it, right? How do you put a patient on a ventilator? Physical examination of the chest. Ideally, the patient you should do this at least once every shift. The examination should include inspection, palpation, percussion, auscultation of the chest, right? Then you record these in the charts, compare them to what was previously recorded. So anything that's changed significantly should be evaluated and treated. So difference in their physical findings, like let's say the patient's more hyperresonant on the chest with severe asthma or air trapping, well, that could indicate they're getting worse, right? Breath sounds and chest excursion are diminished, accessory muscle use is increased, high-pitched wheezes are present. Guess what? This patient's getting worse and we need to control that. Well, would you get that from just looking at vent numbers? Maybe, maybe not. Right? For patients with pneumonia, the chest would be dull to percussions, the breath sounds would be decreased. You'd hear crackles that occur late in inspiration in the affected area. So that's something that you would see there. And let's say it's a pleural effusion. The affected area would be a dull note. Breath sounds would be very distant or absent. You might even hear a friction rub, a pleural friction rub. So patients with a large pneumothorax might even see tracheal positioning to the opposite side, right, to the unaffected side. So chest percussion in these patients with like a pneumo would be hyperresonant over the affected area. Do you need to get a chest x-ray? Probably, but what's going to be pretty quick? The percussion, right? It's going to be a lot faster than chest x-ray most of the time. You would have absent breath sounds in that pneumothorax, right? So auscultation of the chest, if you have low-pitched breath sounds with a rattle quality, some people call that rhonchi, or coarse crackles, it may indicate secretions are in the larger airways, the conducting airways, and the patient could need suctioning. The presence of wheezing usually suggests bronchodilator therapy might be in need. Although wheezes can occur when secretions are retained in small airways as well, and even with some cardiac conditions. So be careful of that as well. Absence of breath sounds usually indicate a pneumothorax, complete airway obstruction, complete lung collapse, improper placement of the ET tube, like a main stem, or even a pleural effusion that we just talked about. So evaluation of both the physical and vent findings, like the PIP, Increasing PIPs and the chest x-rays can really confirm the presence of any abnormal findings and point to appropriate treatment. So if something significant is changing in this patient's appearance in their physical examination, then maybe that's a time to discuss with the care team about the appropriateness of getting a chest x-ray. Right? Patient assessment should include a respiratory muscle use. Look at the patient. Are they still working hard to breathe on the ventilator? They shouldn't be. If they are, you're not doing it right, right? Increase use of accessory muscles on inspiration or paradoxical breathing. If they're retracting their abdomen in during inspiration and protruding it during exhalation, like they're forcing the breath out, right? They're forcing the breath out, usually means there's an increased work of breathing and there's a potential for respiratory muscle fatigue, even though they're on a ventilator. So in other words, your settings are not appropriate to support that patient. If you see abdominal distension, that could suggest several problems, including postoperative intestinal accumulation of gas, right? If they had a laparoscopic surgery and there's gas that's in there. What if they have air swallowing? What if there's bleeding in the abdomen or ascites, which is fluid in the abdominal space? And all those are restricting and pushing up against the lungs, right? Regardless of the cause of the abdominal distension, it can really decrease compliance and impair the ventilation by applying pressure on that diaphragm. That creates restrictive breathing patterns, restrictive breathing issues. You have less surface area. You have lower lung compliance. So the problem should be corrected. I remember going into a patient's room and his lung compliance was low, his airway pressures were high, obviously, and his oxygenation was low, and they're like, hey, go do something, right? So I go in there and I'm listening to his lungs, very distant, diminished breath sounds, and I palpate his abdomen. Sure enough, it is hard, it is rock, it is full of fluid. So he had really bad ascites and it was restricting his ability to breathe and was back pressuring the ventilator. So really, was it a respiratory issue? It ended up being it, but was the respiratory issue the cause? No, it was the ascites that was restricting and pushing everything up. And even his blood pressure was being inhibited by it too because of the vena cava being compressed in the abdomen. So during your initial assessment of the vented patient, you should evaluate endotracheal tube and tracheostomy tube position. This is going to be important, especially to look at cuff integrity and pressures. When we're looking at this, it's appropriate to make sure that cuff leaks and pressures are adequate for your patient, not to cause harm, right? So cuff pressure measurement should not exceed 20 to 25 millimeters of mercury or 27 to 34 centimeters of water. Now, do understand that different hospitals might have different values for this, especially in ventilator VAP protocols, ventilator acquired condition protocols, ventilator acquired pneumonia protocols. They might have different goals here, but these are just what your book goes by, and this is what we're going to do for now. But understand, your mileage may vary depending on the facility that you're at. So when we're doing this, cuff pressure is typically checked during your initial evaluation at once every 8 to 12 hours to ensure it does not exceed, like I said, 20 to 25 torticellis or millimeters of mercury or 27 to 34 centimeters of water pressure. It's generally accepted that maintaining a cuff pressure below 34 centimeters of water pressure is going to be reducing the risk for tracheal damage of overinflated cuffs. Although pressure transmitted to the tracheal wall generally is lower than the pressure in the cuff, some people believe that using a low cuff pressure reduces the risk for tracheal damage and necrosis associated with tube cuffs. So tracheal damage and necrosis can occur if the cuff pressure is transmitted to the trachea is greater than what's called perfusion pressure. So this is partially important in hypotensive patients. So if you have someone with very low blood pressure, they might be more prone to tracheal damage because their perfusion pressure is overall lower. So they're more prone to that damage. And even the ET tube or tracheostomy cuff, even if it has 34 centimeters of water, it can still exceed perfusion pressure and then cause tracheal necrosis or tracheal damage. So pay attention, low perfusing patient, cuff pressures might have to be lower to avoid that damage as well. Like I said, follow your hospital's policy and procedure, but that's the anatomy and physiology of it, right? Um, Cuff pressure measuring devices are very convenient. Even ventilators now will have cuff pressure monitoring in line with them as well. So the big thing here is you can either have an analog or a digital readout. You might have a small volume of air loss when the pilot balloon is connected to a device. So be aware of that. If it's connected to a device, it might lose some pressure. Usually they're very short connecting tubes. They usually show centimeters of water pressure or millimeters of mercury, depending on the device. Usually some of these can be very inaccurate, not very well quality controlled. You might have to do alternative devices for cuff pressures. But when you're checking a cuff pressure, make sure you suction before you check it. Make sure you suction around the endotracheal tube or the upper airway before deflating, so that reduce the risk of aspirating any secretions if you were to let out any air. So any secretions that are just building up above the cuff, make sure you suction those before you obviously have an opportunity to decrease that pressure. That should help reduce the likelihood of any bacteria that's foaming back there or culturing back there from going to the airway and causing a potential pneumonia. So if those secretions do go into the lower airways, it's been shown to increase the incidence of a patient developing what's called a ventilator-associated pneumonia or ventilator-acquired condition. So the ET tube and tracheostomy cuff pressures can be measured using a millimeter mercury column manometer, like what you use for blood pressure cuff. You can use a 3-way or 4-way stopcock between the cuff pilot balloon and the manometer. What you need to do is make sure that you equalize the pressure of the manometer before the cuff pressure is measured, because it can let out a lot of gas in that tubing. So if it's not done, you can lose a lot of pressure and then deflate the cuff of the patient, and they could have a lot of aspiration secretion. So just make sure they're using a syringe and pressurizing it before you equalize the pressure with the cuff. The amount of pressure added must equal the pressure reading, so make sure it's approximately like 20 to 25 millimeters of mercury, because you're using a blood pressure cuff, right? And it can be used simultaneously with the cuff being inflated and deflated. So there's a 5-step protocol that we'll go over here. All right, what if there is a non-existent or low cuff pressure? Non-existent or low cuff pressure. If the cuff pressure is very low or non-existent, then you should check that the cuff has been properly inflated and in the appropriate position in the airway. I've seen this before where, hey, their cuff pressures are higher, the cuff pressures are higher, the cuff pressures are higher. And then lo and behold, I look in there, get the direct laryngoscopy and look into the airway, and guess what's above the cords? The cuff, right? So they have pretty much a modified supraglottic airway at this point. So if the pressure is still low or absent and continues to drop after inflation, then it could be a leak as well. So something you got to look at there. So is the tube in the right place? Is there a leak in the system? Right? So the location of the leak needs to be determined. If the cuff is inflated to an appropriate pressure and the pilot balloon is clamped, if you clamp the pilot balloon and you listen for air leak in the upper airway, if the leak is present during a positive pressure breath and it can be heard over the neck with the stethoscope, then it might be escaping from the patient's mouth. The cuff continues to lose pressure with the pilot balloon clamped, right? You have the pilot balloon clamped. Then the leak is probably the cuff itself. So as a temporary solution, cuff inflation can be maintained with continuous low flow gas into the pilot balloon until the ET tube can be changed in theory. If the leak is not in the cuff, it may be the pilot balloon or the valve. So to detect those types of leaks, the cuff is inflated, a stopcock is attached to the pilot balloon, and the stopcock is turned to the off position. If the leak is still present, it's located in the pilot balloon, so you ruled that out. So the problem can be solved by clamping the pilot balloon. If the stopcock and the pilot balloon resolves the leak, then the valve is not working, right? So then you know it's the valve versus the pilot balloon. But simply leaving the stopcock on the pilot balloon will temporarily solve the problem. It's not a permanent solution, it's a temporary solution. And the tube should be changed if possible, right? There was a 2-year study of massive airway leaks that produced an important finding that a large number of ET tubes that were removed after apparent defects or damages were actually flawless. So tube malposition was almost the most likely explanation of these results. In other words, the tube position, not the valves, not the leaks, any of that stuff. It was actually the tube position that was most likely the cause for these issues. So investigating the leaking airway should precede any decision to change the tube or to solve the problem. Right, so most of the time check to see if the tube position's right. You can see that on an x-ray. You can listen for it if it's above especially you have to use very high pressures to get a seal. That's usually a sign that it could be malposition. Where are they at the gum, right? Where is the tube positioning at as far as numerically, right? Are they at 17 centimeters at the gum? Probably the tube is too high, right? When we're having a cut in the pilot balloon, an accidental cut in the pilot balloon is common, right? It can happen. It usually happens when people have taped to secure the ET tube. The problem can be remedied pretty easily by positioning a 3-way stopcock between the blunt-tipped needle and inserted into the cut pilot balloon and a syringe, right? So you have a syringe and a blunt-tipped needle, right, and you insert it in there. Some manufacturers have a blunt-tipped needle device with pilot balloons. So there's repair kits that are out there, right? So the blunt tip needle can be inserted into a cut pilot balloon, and the cuff of the ET tube can be reinflated, right? And then you can do the repair kits. What about tube and mouth care, right? Tube and mouth care is something that we have to worry about. Once every shift, usually ET tube should be repositioned in the mouth and retaped if needed. Repositioning of the ET tube helps prevent any pressure injuries to the gums, the mouth, the lips, or nose that can occur as a result of constant pressure of the tube. So oral hygiene also should be performed routinely. Although oral hygiene typically is the responsibility of the patient's nursing staff, a lot of respiratory therapists are involved in this as well. So the process of retaping, repositioning the tube is usually a 2-person procedure. One practitioner holds the tube in place while the other one secures the tube with surgical tape. So what about high cuff pressure? The most common cause of excessively high cuff pressures is simply overinflated cuffs. Occasionally the cuff pressures are high because low tidal volume, high pressure cuffs are used. However, most cuffs currently used are high volume, low pressure types, unless a specialty type of tube is used. So sometimes a higher than acceptable cuff pressure is required to maintain minimum occlusion during ventilation, and none of the problems mentioned are usually present. So there are 2 reasons why this might occur. First, the cuff in the artificial airway might have moved up in the patient's airway and become lodged in the larynx or pharynx. This is one of the most common ones that I've seen, is the tube became very, very high and actually went above the vocal cords, right? So the markings at the lips or teeth or gums, I'll add gums in there, might indicate the depth of the tube in the airway. So this is something you're looking at each time you go in there. Hey, is it 21 centimeters at the gum, 21 centimeters at the teeth, 21 centimeters at the teeth, right? So you got to look at where they're at the teeth or the gum, right? Lips can swell. Teeth or gum, they're not going to traditionally change it. So if a lip swells, then it looks like it's deeper or shallower, right? So the markings at the teeth might indicate the depth of the tube in the airway. So the tube, in this situation, the tube should be moved further down into the airway. So if it's too high. So the ET tube could be also too small for the patient. So if someone uses a 6.0 for a person that's 6.5 feet tall, that's obviously very small tube for a very big person, right? So it's going to take a large volume to require a seal on their trachea. So this is particularly a difficult problem because we might have a tight airway and it might be very difficult to change to a larger tube, especially if they had an issue like vocal cord spasm, upper airway swelling, anything like that. We might have to use a smaller tube. Right. In this situation, if we do want to change it, if we're going to need this tube for several days, or uh, and it's wise to change that tube, then we might need to use a tube changer. I've seen them use bougies as well to do tube changers. The tube changer is inserted into the current endotracheal tube, which is deflated and removed while the tube changer is left in place. A larger ET tube is slid over and inserted over the tube changer to the trachea, and then the tube changer is withdrawn, right? The airway is secured and the patient's connected back to the ventilator. On rare occasions, high cuff pressures may be required to maintain a minimal leak or minimal occlusion because the patient's trachea is dilated at the level of the cuff. Right, you might see this on your long-term patients. Occasionally, the cuff can be repositioned, but a dilated trachea suggests that the cuff has been in place and overinflated for quite some time, resulting in tracheal injury. So there are some long-term fixes to that. Sometimes, especially in your tracheostomy patients, which is where you'll see this the most, you might have to get specialty trachs that are extra long, so that'll go deeper than where they did before. But it's unfortunate, but it can happen. All right, 5-step protocol was developed to minimize the risk of tracheal necrosis associated with cuff overinflation. So I'm hearing you tell yourself, cuff overinflation is an issue. Yes, it is, right? So minimal leak technique should be used whenever possible. A reasonable minimal leak technique should be established, which is only 5 to 100 mLs of tidal volume loss during inhalation. For example, if their tidal volume is 600 mLs and a delivery of exhale tidal volume is 500 to 550 mLs is what you're looking at there. A high volume, low pressure cuff should not require more than 5 mLs for inflation. If it does, the tube is probably too small. So when you're intubating and you have the syringe set for 5 mLs, if it requires more than that to get a seal, then your tube is too small for that patient, right? Should you push all 10 centimeters of water pressure into that cuff? No, right? You shouldn't have to. If the minimal leak cannot be maintained with a volume in the cuff less than 5 mLs, then you should make sure the cuff pressure is less than 25, or that the cuff to tracheal diameter ratio is checked on a chest x-ray. Pretty easy, 1 to 1.5 or less is what you're looking at there. So if steps 1 through 4 cannot be achieved, the patient should be followed for tracheal stenosis for at least 1 year after discharge. There could be issues there. Right, so this is what I was saying there. If the cuff volume is less than 5 mLs, then the practitioner should make sure that the intercuff pressure is less than 25 millimeters of mercury and that the cuff to tracheal diameter is checked on the chest x-ray. So make sure you do that. You probably should have these patients followed or notify them that they should have that followed up with. All right, what if there's an accidental cut in the pilot balloon? Like I said before, this is a common occurrence. It usually, like I said, happens when we tape a tube versus use a securing device. Right. The big thing is to position the three-way stopcock between a blunt needle and a blunt tip needle inserted into the cut pilot balloon, and use a syringe. And there's specially designed kits for this as well. So something that you can fix pretty easily. A pilot balloon repair kit a lot of times, and then if need be, you could always replace the airway as well. All right, what about tube and mouth care? About once a shift, we need to reposition like what we were talking about before. Repositioning helps prevent pressure injuries to the gums, the lips, the nose, so on and so forth. Oral hygiene should be done before we move the tube around, and things like deflating the cuff or checking cuff pressures to avoid any aspiration in there. So Uh, Oral hygiene traditionally is done by the nursing staff. However, the RT can be involved here. Where I worked, the RTs were very involved in the oral hygiene as well. So that helps prevent any bacteria or anything from the back of the oral pharynx from falling into the trachea and causing a ventilator-acquired condition or ventilator-associated pneumonia. So monitoring compliance and resistance. This is a big part of ventilator assessment. Normal static compliance is roughly 70 to 100 mLs, right? So that's your tidal volume over plateau minus end expiratory pressure is the equation. When static compliance is less than 25, work of breathing is very high, right? That's because their lungs are so stiff, they're having a hard time taking a deep breath. So they're working harder to get more gas flow so they can get more diffusion, right? The accuracy of static compliance depends on the accuracy of the delivered tidal volume and then the plateau measurement. So if the patient's actively exhaling, remember, they're actively exhaling. It's not an accurate measurement for plateau pressure or for PEEP total when it's during expiratory pause. Chest wall recoil and the elastic recoil of the patient circuit are fairly constant in most patients. A change in static compliance readings over time usually is considered the result of the alveolar elastic recoil. So in cases in which the chest wall compliance does change, static compliance readings can be used to identify the presence of a significant problem. For example, what if there's air trapping or pulmonary edema or atelectasis, a consolidation, a pneumonia, a pneumothorax, a hemothorax, a pleural effusion? A pleural effusion will cause a decrease in static compliance. So reductions in chest wall compliance can also occur with flail chest, changes in the chest wall muscle tension, like what we see with spinal cord injury patients, a pneumomediastinum, abdominal distension, peritonitis, ascites, herniation, abdominal bleeding. So we need to detect any of these conditions by evaluating breath sounds, percussion notes, palpation. Palpation is a very, very important thing of the chest and abdominal wall. Obtaining a chest x-ray when it's appropriate, and looking at their lab data when it's appropriate. But regardless of the method we use to determine the abdominal that an abdominal condition exists, we need appropriate medical intervention must be initiated to help correct the problem. So if we see reductions in their static compliance, then we know that ventilation is going to be less effective. So we know that they're going to be more hypercarbic, more hypoxic, right? They're going to have more issues with diffusion, more issues with ventilation. So if they're in pressure control, CMV, pressure remains constant, but their tidal volume will decrease, right? In volume control ventilation, the PIP and plateau will increase while delivered tidal volume remains fairly constant. So that's the advantage of that volume controlled is we got a very good minute ventilation that's stable, but the pressure's not so stable, right? So in pressure control CMV, if this happens, we need to increase their pressure because as their compliance decreases, so does their tidal volume delivery. So we're going to have to compensate by increasing our PIP, right? So reduced static compliance can result in a lower PaO2 and an increased CO2 pressure as well. So knowing or determining the cause of the condition and treating what's causing their compliance to go downhill is fairly important, especially if it's something abdominal that's pressure or something in the pleural space, right? Anything like that, we can really treat that versus going up on our vent settings. What about dynamic compliance? So dynamic compliance is also known as dynamic effective compliance, is the volume by the ventilator, right, over, so the peak pressure, the volume of the deliver, tidal volume of the ventilator over your PIP minus your end expiratory pressure. So static compliance was your tidal volume over your plat minus end expiratory pressure. This one's the same equation except for instead of plateau, you use PIP, right? So tidal volume over PIP minus end expiratory pressure. So the dynamic compliance is measured during flow. So there's no inspiratory pause here. It's influenced by the patient's lung and chest wall elastic recoil and airway resistance. So in ET tube, the ventilator circuit, because the dynamic compliance includes both compliance and resistance components, it's more accurately described as what's called impedance measurement. So most people still refer to it as dynamic compliance. So the dynamic compliance decreases whenever static compliance decreases, or if raw increases. So decreases in lung elasticity can be easily differentiated from airway problems by monitoring changes in PIP, plateau, and the difference between them. The PTA, trans-airway pressure, is the difference between PIP and plateau. So PIP and plateau are both increasing. They go together. They're holding hands. They're in a compliant relationship. So PIP and plateau are both increasing with the same volume delivery. The PTA is constant, then compliance is what's going down. So if PIP and plateau are holding hands, they're in a compliant relationship. If they go everywhere together, it's a change of compliance, right? But if PIP increases along with PTA, that means it's a raw relationship. So PIP changes and plateau stays at home, it doesn't move, then we know it's a change in airway resistance. So that will help tell us, is this a raw issue, compliance issue? All right, we can see it from there. So when we're looking at this, delivery of the pressure may become dangerously high in these raw patients. So a decrease in dynamic compliance could result in a reduction in their delivered tidal volume as they're on pressure control ventilation. Pressure, therefore, might need to be increased to give them appropriate tidal volume. If they're on volume control ventilation, a decreasing PIP with a constant delivered tidal volume might mean their compliance is improving, or their raw, right, has been improving, like the bronchodilators are finally kicking in. So it's important to measure the delivered tidal volumes because a decreasing pressure might also indicate a leak as well. So that's something else we have to take into account. So when we're looking at pressure control, an increased tidal volume delivery, if you see 400 mLs, 402, 400 mLs, and then you go in and see this patient, now it's 600 mLs. Well, the tidal volume delivery increased, so with that same pressure change, which indicates that their compliance might have improved, their lungs might be healthier, the steroids kicked in, right, whatever happened, or their raw has gone down. Hey, the steroids kicked in and bronchodilators are working, right? So we got to watch all these things. We got to look at their compliance, whether it's dynamic, static, both, right? We got to look at that. Airway resistance is the sum of raw and tissue resistance. Usually it's constant in most cases. Normally ranges from 0.6 to 2.4 centimeters of water per liter per second, right? Per second is the big thing because ventilators usually measure flow rate in liters per minute. So we usually have to divide. So it can be estimated by measuring the PTA and using the inspiratory flow rate on a constant waveform. Although it's not an accurate flow measure, it can be used over time to indicate relative changes in air resistance. So if the PIP is 35 and the plat is 34 and the flow is 30 liters per minute, then we can calculate this, right? But most microprocessor controlled ventilators use software that calculate and display the compliance and resistance values. Some of these can be taken from measurements of pressure, of expired flow and volume. Big thing is treatment for increased raw should be directed to the specific cause for the increase. If it's secretions, if it's bronchospasm, if it's secretions in the airway, then suctioning, if clearing the obstruction, or if they're wheezing, giving a bronchodilator treatment might correct that problem. All right, static curves. So when we're looking at this, the pressure-volume relationship for dynamic and static compliance can be plotted by ventilating the lung at different volumes and recording the PIP and plateau. So there was a study by Bone and colleagues that first described a bedside measurement technique for drawing static pressure volume curves well over 40 years ago. And then they would plot the PV curves. And this is something that's a valuable tool. In some ventilators, I think the Hamilton has a version of this. I don't get paid by any of the vent companies. For obtaining a static PV curve. So currently, they're equipped with computer software and graphic displays that can automatically generate a PV loop and save a reference loop and make comparisons over time. So ventilator graphics have really helped over time. And a lot of people do a daily evaluation of the pressure volume loop, whether it's static or dynamic, to track the progression of the lung compliance and raw changes. So here we're looking at lower inflection points. If you see a lower inflection point, usually marks a significant change in the slope of the curve. It may indicate the pressure at which the large numbers of alveoli were finally recruited. So what they recommend is setting the PEEP above the lower inflection point of a curve, and that might help prevent inflated alveoli from collapsing again. And I'll show you some pictures here. The upper inflection point you'll see indicates the point at which large numbers of alveoli are becoming overinflated. So setting the tidal volume low enough so that the PIP remains below the upper inflection point may reduce the risk of ventilator-induced lung injury as well. So you try to ventilate in between both the lower and upper inflection points, ideally to help avoid overinflation and alveolar trauma. So here you see the pressure volume curves reflecting changes under normal conditions. So this is pictures like here's the static compliance, dynamic compliance. The curves are pretty similar, right? Do you not see the curves pretty similar? Right? Because pulmonary emboli don't really affect resistance or compliance, neither curve changes with this condition. With mucus plugging or bronchospasm, this condition increases. Do you see this? Right, this is this graph right here, right? With mucus plugging or bronchospasm, the airway resistance increases and the dynamic compliance shifts to the right and flattens out. Because there's more pressure required for this patient, and the static compliance remains unchanged, right? So with conditions that reduce compliance, both curves will shift and flatten. So when we're looking at this, it's been shown to be pretty useful in treatment for patients with ARDS. During procedures for obtaining a PV curve, the patient is typically heavily sedated. Sometimes they'll use a short-acting paralytic on these patients. And making sure that ventilator has the appropriate software to get these measurements. They can do a super syringe, a 1 to 3 liter super syringe as well. Attached to the ET tube for precise volumes are pushed into the lung. They're held for about 2 seconds, long enough to allow the measurement of plateau pressure. The pressure is then measured at the delivered each volume. It's kind of a cool thing, but that is one way of doing it. But understand there are other ventilators that have different ways of doing this. But the big take-home point to remember is setting the PEEP above the lower inflection point on the curve may help prevent alveoli, inflated alveoli from collapsing, alveolar trauma, and having to re-expand with each breath. So it's that shearing force, that alveolar trauma, having to re-expand and pull open with each breath. So setting the tidal volume low enough so that the PIP remains below the upper inflection point might reduce the risk for ventilator-induced lung injury. So we should assess the clinical data to help make sure that we're not causing an issue. So looking at that inflection point might really help us avoid causing harm while they're on a patient. And it could help us give a lot more detailed information. Now, obviously, I have a whole ventilator graphics PowerPoint talking about this, but if you go to Chapter 9, it really includes an overview of ventilator graphics along with examples of the graphics. Additional information about the mechanics is going to be a whole separate chapter, but specific procedures for obtaining and using a PV curve changes, especially for patients with ARDS. So make sure that you're using the appropriate settings, and using vent graphics can be very helpful in making sure you have appropriate settings. So here is a pressure volume curve for normal lungs and the lungs of patients with acute respiratory distress syndrome. So the normal one's up here, and then your ARDS one is over here, right? Note the lower and upper inflection points on the pressure volume curves for ARDS. So when we're looking at this, do you see how much pressure? It takes a lot more pressure, right, to get this stiff lung to open up, and over here, hardly any pressure for the normal lungs. So what they recommend is ventilating in between the lower inflection point and the upper inflection point. So ideally, you're not over distending and you're not allowing for complete collapse either. So that's what I meant earlier with that previous slide of making sure you don't overextend or underextend. Ideally, you'd want to ventilate in this area here between the upper and lower inflection points. Right, and here's a graphic that was in your book, and I thought this was pretty useful. I'm a big fan of tables and flowcharts and all those things here. So this is a table showing different ways to assess ARDS. For an example, it has low static compliance, low dynamic compliance. Chest X-ray usually shows diffuse infiltration. Their oxygen levels in the bloodstream, PO2 is low, right? And then treatment for this, PEEP and supportive care, because they need that distending pressure. They might need that PEEP increased above that lower inflection point. Right? And then you look at something like bronchospasm. Static compliance usually has no change. Dynamic compliance usually decreases. Possible hyperinflation would be a sign that you would see on their chest x-ray. PO2 is going to be decreased, of course, because ventilation can be sacrificed. And bronchodilator therapy would be your primary treatment. So I thought this was a pretty cool little chart to have on yourself. Might be a little handy badge card one day, who knows? But it's one of those things that I thought was pretty neat that your book provided. All right, so here are some examples to play with. So what we're going to look at here is we have a patient on pressure-controlled continuous mandatory ventilation, and we see a decreasing in dynamic compliance. So at 1 o'clock, we go in there, and we have a PIP set at 25. So all three of these at all three time intervals, 1, 2, and 3 o'clock, we have a constant pressure set. But what do we see happen? Our tidal volume is 500 mLs. Oh, that's good, right? And then at 2 o'clock, it's 400. Then at 3 o'clock, it's 300 mLs. So what's happening with our compliance? Well, our compliance is progressively decreasing, decreasing, and decreasing. So it's saying that on pressure control ventilation, volume varies, which you already know, and our volume would decrease as compliance decreases. So the stiffer the lungs, the harder it is to get their volumes. All right, here we have a patient on volume controlled. And so here on volume controlled, see our tidal volumes are what's controlled. So they're going to stay the same no matter what, unless we change them for some reason. But what changes is the lung characteristics. What changes there? So in this situation, at 1 o'clock, our PIP was 25. Then we go in at 2 o'clock, our PIP is 30. We go in at 3 o'clock, our PIP is 35, right? So what's happening? It's taking more pressure to deliver that same volume. So in other words, compliance, our lungs are getting stiffer, right? So we go from a compliance of 20 to 17 to 14. So here we can see a pattern of our compliance decreasing. All right, so here we see a situation where we have a decreasing static compliance and dynamic compliance during volume control ventilation where the air resistance doesn't change. So this is all giving you, these slides are giving you patterns to start to recognize. So that way when you see these on your patients, you understand what pattern they're showing you. So here we're going to have a patient at 1 o'clock. And we're on volume control ventilation. So 1 o'clock, 2 o'clock, and 3 o'clock, their tidal volumes are the same, right? 500 mLs. We didn't change those. But one of the things that we see is that every time we go in, it takes more pressure to deliver the breath. We're like, okay, so it takes more pressure to deliver the breath, so it could be a compliance issue, or it could be an airway resistance issue. Well, I don't know which one. Well, let's look further. When we're looking at this, one of the biggest things to look at between for airway resistance versus compliance issues is look at the PTA. It's the difference between the PIP and the plateau. The PIP and the plateau. So if our PIP's 25 and our plateau is 20, so our PTA is 5, okay? Our PIP over here at 2 o'clock is 30. Our plateau is 25. Our PTA stayed the same. They went up together. So remember, in a compliant relationship, they go together everywhere. They hold hands, right? So PIP and Plat are in a relationship together. They're holding hands. And if one goes somewhere, the other one goes with them because they're holding hands. They can't not hold hands, right? So both of them went up together. Both PIP and Plat went up together. And at 3 o'clock, my PIP is 35, my plateau is 30. What happened? Well, both my PIP and Plat are holding hands still. They're both in a compliant relationship still. So my PTA, my change of pressure, is still only 5. So this is a compliance issue. And because they both went up together, that means their compliance is decreasing, right? Do you see that it's a decreased compliance? Air resistance stayed the same. Air resistance is the change of airway pressure, the PTA, right? Air resistance stayed the same here, and it was a compliant change, right? So increasing PIP and plateau, the volume and pressure lost to the airways are constant, right? So we're going to have a PTA at the same. The lung is less compliant. The lung is stiffer in this scenario. So this could be a good example of a pneumonia. All right, what about a patient that is in volume control ventilation, decreased dynamic compliance, a constant static compliance, and an increased raw? Okay, that was a lot to say, but here, watch this. All right, they're in volume control ventilation, so time volume is the same no matter what. All right, now I'm going to go over here. I need to see what's going on with my patient. 1 o'clock, their PIP was 25. 2 o'clock, their PIP was 30. 3 o'clock, it was 35, so my PIP's going up. All right. Let's see if this is a compliant relationship or a raw relationship. All right. So here I'm going to look at my plateau pressure. The 25 over 20, my change in airway pressure is 5. Okay. Then at 2 o'clock, 30 over 20, so my PTA went up. It did not stay the same. So my plateau stayed the same, but my transairway pressure increased. Okay. At 3 o'clock, my plateau pressure stayed the same. Notice all three of these, the plateau stayed the same. So if one person in a relationship stays at home and the other one goes out, it's a raw relationship. It is a raw relationship. So here you see the PTA changing. 5, 10, 15, right? That PTA changes. So this is a raw relationship. Notice that the dynamic compliance decreased even though the static compliance was the same. So that's showing you that this is an increased issue with air resistance. Could be bronchospasm, kinked tube, so on and so forth, right? So we need to make sure to troubleshoot this. And this is all to give you a pattern. The way that I remember it is if it's a raw or compliant relationship, if it's compliant, PIP and plateau hold hands. They both increase or decrease together. Their PTA stays the same. Their distance is always the same. But if one stays where it's at and the other one leaves, changes significantly, then it's a raw relationship. All right, so what do we have if we have an improved compliance? So here we see volume, targeted ventilation, which is very common. All right, I look at my PIPs. At 1 o'clock, there were 25. 2 o'clock, 23. 3 o'clock, 20. Okay, we're doing better, right? Our pressures that we're taking to ventilate are a lot lower. All right, now I'm going to look at my plateau pressure. 23, 21, 18. So my PTA stayed the same this whole time. So anything happened with my raw? Nothing happened with my raw, right? My plateau and PIP stayed the same. They were both together, right? Both together. So this patient's lung compliance, it changed. But in this situation, Since both of them are holding hands and they're decreasing, that means I have a much more compliant lung tissue. It's a lot easier to move. The relationship is healthier, if you will. They're holding hands, but it's a lot healthier lung tissue. Holding hands, right? So this is a increased compliance. So this could easily happen when we have a patient where the medication starts to kick in when they start to recover. All right. So this is a different situation. We have a patient here where we have the volume set, right? And then now the big thing that we're changing here is the PEEP value, which is right here, right next to the volume. So we're going from a PEEP of 5 to a PEEP of 10 to a PEEP of 12, right? So when we're increasing PEEP in this situation, what happens to our PIP and our plat? So here we have our baseline, a PIP of 30 and a plat of 28, a PTA of 2. So when I increase it to at 2 o'clock, our PIP of 35, plateau of 33, PTA of 2. So our compliance changed. Now, did compliance go up or did compliance go down? Well, since it's taking more pressure, our compliance decreased. All right, at 3 o'clock, our PIP went up and so did our plateau, and our compliance, right, decreased. So the addition of an increasing PEEP results in increasing PIP and plateau pressures. So one of the things that we're going to see here is that can easily cause an issue, especially with their airway pressures. So if someone's airway pressures are too excessive, we might have to turn down their PEEP in order to have good plateau pressures, because we try to keep the plateau under 30. So we might have to take this person's PEEP back to 5 if you're looking at this, right, where the plateau pressure was under 30. So that might be more appropriate for this patient, because now they might be over distended and causing a lot of issues. All right, so the comments section on the patient ventilator sheet, you can use this section to comment on any of the following things: your patient assessment, which includes your breath sounds, your chest wall movements, percussion notes, cyanosis, cutaneous perfusion, right? Level of consciousness, right? So other things that we have to look at is changes in the patient ventilator settings, of course, the changes in the physician orders, or description of any equipment problems, like, hey, you had a cuff leak, or you had a cut pilot balloon, right? What all went on there, right? That type of thing would go under the comments section. Some medical centers use a separate patient assessment sheet in which subjective findings, objective findings, the assessment, and the treatment plan, or SOAP notes, can be summarized, right? In some places you could still be doing those as well. So always know the system that you're going to be using, and make sure that you're able to understand what information they want in each place. All right, some concept checks really quick. The initial assessment of a patient receiving mechanical ventilation should include the evaluation of a patient's physical appearance, right? Skin color, is it mottled, pale gray? Is it pink, well perfused? Vital signs, ABG, SpO2, and vent settings, right? Initial assessment of a patient receiving mechanical ventilation should include evaluations of their physical appearance, vital signs, ABGs, SpO2, vent settings like their frequency, sensitivity, FiO2, volumes and pressures, right? And their vent settings, right? So hopefully you got all that in there. You can always rewind it if you need to. When we're looking at this, volumes, we're now at the next bullet point here. Volumes, pressures, temperature, vital signs, and FiO2 are measured during each ventilator assessment. Once again, volumes, pressures, temperature, vital signs, and FiO2 are measured during each ventilator assessment. The next one down here, initial assessment of the position of the ET tube and cuff pressure measurements establishes that the ET tube is positioned properly and that the cuff pressures have been set correctly. Once again, initial assessment of the position of the ET tube. Initial assessment of the position of the ET tube and the cuff pressure measurements establishes that the ET tube is positioned properly. And that the cuff pressures have been set correctly. And finally, the last one down here, calculation of dead space to tidal volume ratio, compliance and resistance, and evaluation of the PV curves when we're looking at inflection points can help determine a baseline condition of the lung mechanics and can help us serve as means to monitor changes, right? As means to monitor changes. So calculation of dead space to tidal volume ratio, compliance, raw, and looking at PV loops, right? And looking at PV loops and curves, right, can really help us, especially when we're looking at where to set our low inflection point versus upper inflection point settings are. All right, last slide. I know you're done with this by now, but evaluation of the integrity of the ventilator circuit is part of a standard ventilator check, and it includes checking for leaks, disconnected tubing, or other circuit problems. Evaluation of the integrity of the ventilator circuit is part of a standard ventilator check. It includes checking for leaks, disconnected tubing, and other circuit problems. And then the next one here, visual and auditory alarms are essential components of a patient ventilator system. So you need to make sure that the alarms are visual and auditory because they are essential to making sure that the patient is safe. And finally, the last one, computerized ventilator graphics. Included in most ICU ventilators have extended our ability to perform bedside assessments of the patient-ventilator interaction. Those graphics really do help us see what's happening with their compliance, their resistance, as well as ways that we know if we're being therapeutic with their lung mechanics as well. So hopefully, I know this was a long one, but hopefully you got some good stuff out of your initial assessment. Once again, take breaks, go ahead and summarize your notes and outline things, and make sure that you're really going through this. The more practice you have with initial ventilator assessment, the better you'll be, the more clear this video will appear to you.